Hello, and thank you for having me. For those who don't know me, my name is Brandon Jonard. I'm an assistant professor here at Case Western Reserve University, new to the department in the Department of Orthopedics within the Division of Orthopedic Trauma as well as Oncology. I have no disclosures as it relates to this talk. I will be speaking about a number of different implants, one of which I have used more exclusively. So I'll focus on the terms of surgical technique on that implant, but I am not a consultant of them. I receive no stipends or anything like that. And I do not have any data that would suggest any implant that I'll have in this talk is superior to any others. A little bit of background on myself since I'm new to faculty here is I studied mechanical engineering at The Ohio State University and then got my medical degree at Northeast Ohio Medical University before completing residency at Summa Health in Akron, Ohio. I then completed subspecialty training in orthopedic trauma at Indiana University in Indianapolis, and then did my orthopedic oncology training at the James, again returning to Ohio State in Columbus, which is where I did most of my osseointegration training. So the topics that we're going to cover today are a little bit on the history of osseointegration, or what you may see me refer to the rest of the talk as OI. Some modern day indications. So we'll talk a little bit about surgical planning, and I'll show you some of the steps that go along the way in performing these operations for patients who have a history of amputation. We'll go over some of the postoperative care and rehabilitation, and then we'll talk about some studies that go over outcomes as well as potential future directions for where we're heading. So to give us a little bit of background, in 2005, at least, there was an estimated 1.6 million amputees in the US, or about 1 in 200 people. And that number was expected to double by 2050. Most of these are due to things that I treat, such as trauma or oncology, but there are a number of others who are due to other conditions such as diabetes or peripheral vascular disease. And about 3/4 of these patients can be expected to have some sort of prosthetic or socket-related complication, most commonly ulcerations, excessive perspiration, refitting, or need for new implants, or socket size changes. Osseointegration is defined as a procedure in which a metal implant is directly anchored into the residual bone on the residual limb, which is then attached to a prosthetic through a transcutaneous connector in the skin or small hole in the skin, which we also call a stoma. Similar concepts have been used in dental surgery for a number of years, and that'll bring us a little bit to the history of what kind of brought us to this. So the first OI procedure performed for an amputee was actually performed in Sweden in 1990. And this was based off of research that had been done for approximately 40 years prior to that by Per-Ingvar Brainmark, who was a Swedish maxillofacial surgeon who came up with the idea of osseointegrated implants for dental implants. His research actually started in the 1950s, and he performed his first successful OI dental implant in 1965. In the United States, we actually tried a number of years ago to adapt this technology. Most notably within the United States at Rancho Los Amigos National Rehab Center in Los Angeles. But those efforts were pretty quickly abandoned due to a number of complications, including loosening, infection, as well as osteomyelitis. Of note, most of these were cemented implants at that time, which is a stark difference of what we use today. So common day indications, the main indication is any patient who has complications with a conventional socket-based prosthesis. They need to have adequate bone stock proximally. They need to be skeleton mature. They need to be in good overall health. They need to be compliant with the postoperative protocols and motivated to proceed with the multiple stage operations that are necessary. And in general, the age is usually between 18 and 70, although depending on the study, that may vary a little younger, a little older. Some contraindications would be skeleton immature, active infection, peripheral vascular disease, and diabetes. I'll put a little asterisk too. They may be more of a relative contraindication because there are people who are trying to look into performing these procedures on these patients. Definitely, though, chemotherapy or anybody who's actively immunocompromised, smoking, osteoporosis, somebody with metabolic bone disease, obesity, or anybody who's had prior radiation to the area that would prevent bony ingrowth. For the majority of this talk, what we're going to focus on is really lower extremity amputations, and in particular, transfemoral. There are definitely people out there who are doing these for transtibial, which we'll talk about a little bit, as well as for upper extremity amputations, most commonly for transhumeral. Just for the purposes of this talk, with the limitations on time, we're really going to focus on the lower extremity amputations. So what are the challenges? Infection is obviously one of the biggest ones, both superficial as well as deep infections, as well as bone infections and osteomyelitis, and then going along with that septic implants. Skin complications are also a big problem. You can see here in the lower right hand, this is evidence of skin necrosis from the transcutaneous stoma that was created during the second stage of the procedure, where the skin around the stoma basically dies. You still have longer term complications such as implant loosening, stress shielding, as well as peri-implant fracture. So what are the things you have to think about then when you're going through and planning in this case? I will tell you that there are, I'm trained in orthopedics, and there are orthopedic surgeons out there at select centers who do each stage of this procedure on their own. And I think that's absolutely fine as long as the person's comfortable with it. It is my opinion that you need a multidisciplinary, multifaceted team to execute this operation adequately, especially if somebody has a complication. So for me, I think involvement of plastic surgery is a must. And in my opinion, their job is much more important than mine, where I would just be placing the implant. They are really in control of shaping that residual limb. They perform an aggressive thighplasty, which, if you haven't seen it before, if you look here on the lower left-hand portion of the screen, this is a person standing up, donning their prosthesis. And what you see is this redundant tissue on the medial side that's skin, subcutaneous fat, muscle. Well, that rests directly on the implant when they're standing, which can cause skin ulcerations and irritation, but also it creates a moist, warm environment at the stoma site for bacteria to then reside. So it's really important to get all of that tightened up so that you don't have that muscle resting on the implant at the stoma site. Their largest job that they have is to decrease motion at the stoma site, because that's really the key to prevent these things from either forming hypergranulation tissue or forming infection. So in most instances, and then the implant that I've used, what we do is basically tuck down all of the muscle, down the fascia, and to the end of the bone that you're left with. You then basically strip down the underside of the skin, all of the subcutaneous fats, basically down to the point of seeing hair follicles on the underside of the skin, which is it goes against everything we've ever been taught in surgery to do. But the idea is to decrease the thickness of skin that is between the environment and the end of the bone, to decrease the amount of motion that's possible. And you basically just want the skin to scar down to the bone so that nothing moves. There are other techniques where some people will actually take the skin and attach it to implants themselves to see if they can get skin ingrowth into the implants. It just varies based on your technique. Another thing that I'm a big proponent of in these patients is targeted muscle reinnervation, or TMR. We've seen this in other amputees, that it decreases postoperative pain as well as phantom limb pain. You see a decrease in neuroma formation, which then potentially enables more effective postoperative rehabilitation as well as prosthetic use in the postoperative period. With more modern prostheses, there's also potential then to adapt this for the use of potentially powering prostheses or providing proprioception. So if a patient hasn't had TMR from a prior amputation and we're performing this, I would always recommend for our plastic surgeons to then perform this at the time of our first stage. These are a list of a number of implants that are out there. And if I don't think it's important to know the details of each and every one of them, but I think what it's important to know is just some of the major differences. So the OPRO, which is actually the one that I use most commonly, it stands for Osseointegrated Prosthesis for Rehabilitation of Amputees. It's actually the only FDA approved prosthetic in the US right now. Is based off of Brainmark's original work, which is basically a threaded implant that goes into the end of the femur. It's a two-stage procedure. A number of these other implants are based off of differing technologies, and most of them are press fit in the bone, relying on an interference fit between the bone as well as the implants. And depending on which implant you use, they're used in varying degrees in different countries. For example, OPRA is used extensively in Sweden, where Brainmark did his original work. The IOP and the OPO are used a lot in Australia. Different things are used in different areas based off of that region's preference. There are also slightly differences in just when you look at the number of stages that you use. So the procedure that I typically perform is a two-stage procedure separated by 3 months, but some other ones are a one-stage procedure. So there are slight differences. There are slight differences in protocols, but the general rules and schemes between each one are the same. So what are the stages that I've been talking about? So stage one involves the aggressive thighplasty or reshaping of the residual limb that's there. It involves freshening up the end of the distal femur, where you essentially cut off a little bit of distal femur where you may have some hypertrophic bone that is formed to create a good platform to then anchor soft tissues later. You then place our implant as well as some bone graft behind it, followed by a cap to hold the bone in place, and then plus or minus whether or not the patient needs TMR at the time of that initial surgery. That's the end of stage one. You close up, and then you put the patient on ice basically for 3 months. 3 months later, we open the patient back up. We verify that there's been bone graft consolidation around the implants. The flaps are revised, plus or minus potentially additional thigh-plasty if needed. At this point, that you then secure muscle and fascia to the end of the femur as well as periosteum to create a solid base and for which you to then place your stoma to. The abutment, which is the portion I'll show you here in a minute, is the portion that comes out of the stoma to then attach to the implants, is inserted. You create the stoma, you try to eliminate motion at that site. At the end of that procedure, it's typically 3 months before we're allowing them to go full weight bearing. And we'll go over a little bit of the postoperative rehab here in a minute. This is kind of what it looks like when you're going through the preoperative staging or preoperative planning. We usually get a CT of the residual limb to really plan for what size implant we use. Because these usually have to get flown in, we want to have an idea of roughly the size we're going to use. So we get coronal and sagittal scans to see what size implant we use. And what I'll do is I'll blow up this area here. What they do is then send you a basically plan that says, hey, here's where your cut's going to be. Here's how far your implant needs to be seated. This gives you this amount of fixture distance based off of the CT for where your implant's going to sit. So they really kind of give you a really good plan moving forward of exactly the steps you need to do in order to execute it. And then again, this is just a close-up showing based off of their schematics, the size implant they think you can use, as well as how much you have residual bone you have to resect to get the appropriate amount of implant within the bone. This is an intraoperative fluoro shot after I placed one of these implants. This is actually the first one I did, showing the threaded implant within the bone. And what you can see here, I'll kind of use the mouse here, this area here in between the bone and the residual implant at the end, this is all bone graft that has been placed behind there. So over the first 3 months, this should all hopefully incorporate. After this caprum is removed, all you'll have left is this opening where the abutment screw goes, but then the entire implant's actually completely encased in bone, hopefully then preventing, if the patient gets some sort of infection, hopefully preventing a septic implant because it's completely protected by the bone that has been replaced. This is a good intraoperative shot after we've threaded the inside of the femur, showing exactly what it looks like. You can see those threads that have been cut in there. It is not rocket science to put one of these in, but you kind of have to know little small details of each step along the way. This is after stage 2. So this is after the abutment's been placed, the stoma's been created. You can see this is actually that same patient. This was the first one we did. You can still see he has a little bit of hypergranulation tissue in this area, but he is actually tolerating it very well. But this is the abutment sticking out, which then will allow you to then don the prosthetic. The typical postoperative protocol that we've used is you're non-weight bearing for the first month following your second stage. You're also non-weight bearing for the entire 3 months between stage 1 and 2. You then have progressive weight bearing limited to usually a few hours a day over the first 3 months. And the goal is to get to full weight bearing off of crutches by 6 months. This is all based off of basic science research that would suggest that with these porous titanium coated implants, you get about 50% of your bone ingrowth in the first 3 months, and you get about another 25% over the next 3 months to 12 months. But after the first 3 months, you usually have enough bone ingrowth to fully support weight and prevent pullout. This is our patient actually getting up and working with therapy. He had many socket-related complications over his years prior. His amputation was secondary to an osteosarcoma. So he had been dealing with this for almost 10 years until we performed this procedure for him. He had been using his socket less and less because of the issues. And this was after we performed this. I actually have a video on my phone of the first time he'd been up walking on a prosthetic in almost 2 years. This is what a prosthetic then looks like. You can see based off of that square abutment, that abutment goes into the top of the implant, which basically twists to unlock, twists back to lock. So if you've ever seen a patient don a prosthetic, it can sometimes be a real pain in the butt, especially if you imagine just them doing day-to-day things, like just having to get up and use the restroom in the middle of the night. Getting your prosthetic on to do that can be a hassle. This is quick, it's easy. There are many fail-safes within this that would prevent them from transferring a potential force up into the femur. So for example, if the patient catches his foot walking off a curb, you may think, well, this could then twist the implant, which would potentially fracture the patient's femur. There's a fail-safe in here where this knee mechanism is designed to unhinge potentially if it sees an excessive force. Additionally, the abutment screw that attaches the abutment to the implant within the femur is designed to break, so that if somebody were to potentially put a excessive torsional force through their femur that would potentially break them, hopefully that screw would break first, which would require revision surgery, but much less of a revision surgery than somebody who broke around their implant. So how about outcomes? So what I can tell you is that the research is variable and it's difficult to make really strong conclusions. There's been at least one systematic review that has made that very conclusion. And the reason for this that we'll go over towards the end here is really just because of a low number of patients who have had this procedure done. So you don't have great sample sizes to study. You also have, as I mentioned before, multiple different implants with multiple different implant technologies. And not every single study is studying the same implant. So it's hard to compare one study to another because techniques are different, implants are different, the patient demographics are all different. But there have been some studies out there that have tried to show outcomes that I still think are important to discuss. So number one, is it safe? This was a study based out of Australia and the Netherlands that was a prospective study between 2009 and 2013 looking at all adverse events. So if you look here, they had 86 patients, about 90 implants. And if you look at the breakdown here, what I think is important just to see, you can kind of break it down to thirds. So about a third of patients had no complications. About a third of patients developed an infection. And I'm going to discuss this grade 1 or 2, and a third of patients developed some other sort of complication that required a revision surgery. So 2/3 of your patients based off this study will get some sort of complication. About a third of patients require secondary surgery. In terms of infection, this grade 1 or 2, this was actually the study that defined grading infections for these OI prosthetics. Basically, a grade 1 infection is just a low-grade superficial infection. A grade 2 infection is a high-grade superficial infection, but both grade 1 and 2s are treated with just oral antibiotics. You don't get into a surgical issue until you get to grade 3 and 4, which are bone infections or osteomyelitis, or grade 4, which would be aseptic implants. That's where you are looking at revision surgeries. So everybody who got an infection in this, just were able to clear it up with oral antibiotics. These are some pictures of what you might see. This was a patient with more significant hypergranulation tissue formation that required a revision just due to irritation of that site. And these are some examples of superficial infections. This was another study looking at patient outcomes in people with transfemoral amputations, looking at both complications as well as patient outcomes, looking at data going out to 5 years. So if you see here, the survival rate of 5 years for these implants was 92%, which is pretty darn good. The revision-free survival, however, is only 45%. So again, many of these patients are getting secondary procedures due to some sort of complication. You see a number of patients have infections. Most of them tend to be superficial, with a small number being deep. You had 4 patients who had implant removal, but you still have a 92% implant survival rate at 5 years. All the patients based off of outcome measures reported improvement in implant use, mobility, as well as physical health-related quality of life. And this graph kind of breaks down when you expect these complications. So the top 2 lines are the 2-year and 5-year complication based off of skin issues. You can see most people had very minor issues, if at all. And basically the light gray and the darker gray bar indicate either no trouble at all or just minor trouble. And that gets you about 90% of patients in the first 2 years. Slightly more start to creep in as you follow them out longer, but it really doesn't change a whole lot. The thing that I think would be really interesting is looking at the second 2 bar graphs, which is again 2 and 5 year complication rates, but looking at things that aren't based off of skin. So these are like mechanical complications and things like that. So still at the 2-year mark, still about 82% of patients have little or no trouble at all with the mechanical or stability aspects of their implants. As you follow them out to 5 years, that number drops off and you start to see some patients who get some major complications. Now, my question for this, and we just don't have the data yet, is what happens as you follow these patients out to 10 years? I think that would be an interesting thing to look at moving forward. This was a survey study just looking at patients who had either OI versus conventional socket prosthesis. And the take-home point from this is that patients with OI had significantly higher global scores on these surveys and significantly lower problems on these surveys. Mobility and use did not necessarily show a big difference. However, they were trending towards a difference. The QTFA is one that we'll talk about a couple of times. That stands for the Questionnaire for Persons with Transfemoral Amputation. That's a very common survey that's given to patients with transfemoral amputations, trying to basically get out of them, how's your mobility, how is your problems, how is your prosthetic use, things such as that. Here's a study based out of the Netherlands, looking again with patients with OI. You see pretty much a theme developing here that you still have a high number of patients who are getting some sort of infection, although most of them, 95% as a matter of fact, are grade 1 or 2. So again, clearing up with just oral antibiotics, very small subset, developing something more that would require some sort of surgical intervention. You saw a couple patients with broken implants. You saw no cases of septic loosening. And in total, there were a handful of patients who had to get some sort of secondary procedure based off of soft tissue refashioning, usually because of thioplasty, hypergranulation tissue, things such as that. I actually really like this photo because I think this really demonstrates what OI does to the residual limb as far as restoring your mechanical axis and then restoring natural weight bearing through the bone. So here on the left, you can see this is a patient who's donning a conventional socket prosthesis. You would assume that there had been a proper adductor myodesis at the time of the original surgery, but still with that leg out like that, you know that the residual implant, not the type that I would typically use. But once you tuck that back in, you restore the mechanical axis, which then should hopefully restore normal mechanical loading of the proximal femur from there on out. So this study was aimed to look at what happens to the proximal femur. And the take-home point from this is they looked at transfemoral amputees as well as transtibial amputees. They looked at bone mineral density pre-surgical as well as at a year and 3 years post-op. They also looked at the 6-minute walk test as well as the timed up and go test, and then tried to come up with some conclusions. What you can see from this is that patients who had, and I'm just going to show you this real quick. These are just two different varieties of the implant they use. Patients who had no screw across their femoral neck, that's just designed to protect the neck so they don't break, who had no screw across the neck, so that'd be more of the picture on the left, had increase in their bone mineral densities that was statistically significant at the 1 and 3 year mark. If they had a screw across the neck, it still got better, just a little slower. They didn't see that difference until the 3 year mark. This is unique to the transfemoral amputees in this study. The transtibial amputees did not necessarily show such a gain in bone mineral density, likely because as they're weight bearing through their transtibial residual limb, the femur is still seeing a closer to normal biomechanical loading at that point. They also saw a correlation based off of their preoperative timed up and go test as well as 6-minute walk test, and that patients who performed better with those tests preoperatively saw less gains moving forward, likely just because they were more active at baseline and were loading their femur more often. So the patients who really saw a benefit to this are the patients who were either non-ambulatory or a little bit slower with those tests. So what about fractures? On the trauma side of thing, I'm always worried about fractures and people fracturing around implants because they can sometimes be a difficult thing to treat. This was a study looking out of Australia where they used pretty much all press fit implants between 2010 and 2018, looking at a little over 500 OI procedures performed total. There were 22 fractures out of that 500 procedures. That's an incidence of about 4% of all cases and about 6% of their transfemoral amputees specifically. So you can basically say it's about a 5% incidence. The take-home points were that despite fracture, there were no OI implants that were removed. Ambulation was not affected after the fracture had healed. So the patients at the end of this time period were still able to ambulate after they'd healed their fracture. The techniques that were used to fix the fracture were techniques that are all orthopedic surgeons, especially trauma surgeons, are used to, and it's usually either some sort of dynamic hip screw or plate fixation technique. And patients did fine. Actually, when you look at the 22 people who fractured specifically, 21 out of the 22 were wearing their osseointegrated mounted implant longer than they would have used a socket prosthesis. And 18 out of the 22 were wearing it more than 16 hours a day, despite the fact that they had a fracture. So even with a fracture, they still long-term did pretty well. They did try to figure out if there was any sort of risk factors that would put you at risk of factor. And basically being female was the only one that really clinically made a difference. There was a small statistical difference with obesity, although clinically, I don't think it really makes a difference. But they saw no difference based off of whether or not you have bilateral implants, time from amputation to OI, age at which your OI was performed, or your bone density at baseline. So how about tibias? This is a study that, again, was just looking at outcomes, but it had a good mix, I thought, of femurs as well as tibias, whereas most studies focus primarily on femurs. Again, they're looking at patient-reported outcomes as well as some surveys, looked at 2 and 6-minute walk tests. As far as complications, they saw 2 periprosthetic fractures, 1 explant for septic loosening, and 1 explant for aseptic loosening. But the overall survival rate of all these implants is about 93%, which is in line with what you see in other literature. Most common complications, again, low-grade soft tissue infections. When you look at these patients when you graph them basically based off of their outcome measures, you can see use gets better, mobility gets better, problems go down, and their global scores go up, okay? So despite the fact that this is not a study looking at just tibias, I think that the fact that it's almost split 50-50 between the two gives you an idea that if you do these for tibias, they probably do okay. It's hard to make a rock solid conclusion from that, but based off of this and some other studies, there seems to be some data that suggests that you might be able to. I do think the one thing you have to be careful of is you can't necessarily use any of the implants for a tibia. In the femur, you have a nice, strong cylindrical portion of bone that you can either press fit, or in the case of me, thread an implant into. If you have somebody with a transtibular amputation, especially a high one, as you get into that metadiaphyseal flare where you're ending up with mostly just cancellous bone, it is hard to get good fixation in that with press fits or threaded implants. So a lot of the people who are using it for tibias are using custom implants, actually, where they can put screw holes in the implant so that they can then secure the implant with screws drilled from the outside of the bone to the inside, so that you can get at least some sort of axial control and then prevent windshield wipering within the proximal tibia. So what about vascular patients? So you'll notice this is two different studies based off of the same series of patients, and you can see the number of patients. We have 5 patients, so you really can't make strong conclusions from this, but this is one of the few studies that's looking at, can you do this for vascular patients? And based off of their very small case series here, the answer would suggest that probably, and it's probably very much dependent on patient selection criteria as well. The take-home point is really that out of the 5 patients who were looked at in the initial 12-month period, 3 of them were actually wheelchair-bound prior to their OI procedure. Afterwards, all 5 patients, including 3 who were wheelchair-bound, were ambulatory, wearing the prosthetic 16 hours a day. In the second study, they basically took that same series and then gained 1 extra patient and looked at the 3 and 5 year mark. Similarly, 4 of the patients at that time period out of the 6 were wearing their prosthetic 16 hours a day. You still saw the same sort of complications with infection and other things like that. 1 patient did have to get a revision. And so in the small series, it would suggest that it's possible. I just think you have to choose your indications very carefully. So what about cost? Because that certainly comes into play. This was a study looking at a Markov model that, instead of going through the details, I think it's better just to kind of give you, again, the punchline of this, which is there certainly is a significant incremental cost of having one of these procedures done. And if you track this over time, the longer you track it as far as a time period that you're tracking, that incremental cost per year gets larger and larger the smaller period of time you would look at, which just makes sense. That being said, if you're comparing it to a socket-based prosthetic, for each incremental decrease in quality of life, for each of those incremental decreases, that incremental cost per year of having an OI procedure done starts to go down. It starts to go down pretty quickly. Okay, so really, for people who don't have socket-based prosthesis complications, it doesn't make monetary sense. But for people who do, the more issues they have, the more it makes sense to probably proceed with a procedure like this. Actually, if you look at this, the prosthetic costs for OI on a year-to-year basis are actually lower than some of the socket-based prostheses on a year-to-year basis. That's actually highlighted by a different study that we'll show right here, which looked at surveys of patients over a 10-year period that saw the patients with OI had fewer workshop visits for their prosthetic on 3 versus 9. They actually had a decreased annual cost for the components as well. And it's not a statistical difference, but this is $500 a year, which for most patients, if you tell them that they can save $500 a year, I think some of them may consider taking that upfront cost to then save the long-term complications and decrease the long-term costs on a year-to-year basis. So what's the verdict? This is something that, while we have been doing it for a period of time now, I think it's something we're getting better understanding of and getting better and better at. But we need better long-term data to tell definitively what is the ultimate fate for OI in patients with lower extremity amputations. The current studies obviously are limited by low enrollment and heterogeneity within the groups. And the outcome measures, and as well as implants, are different depending on the study as well as region that you're talking about. For patients who are high demand, though, who are active, healthy, motivated, and have socket-related complications, I think that OI will likely provide improved prosthetic use, function, as well as patient satisfaction. If I'm counseling patients, that's what I would tell them. There is, however, an upfront cost, which is that initial 6-month period in which you're going through your multi-stage procedure. Certainly, there's a monetary cost associated with it. And I would basically tell every single patient, expect some sort of complication. Likely, it will be one that we can handle with relatively minimal morbidity, but expect some sort of complication. In terms of patients with other underlying medical comorbidities, I think the verdict is still out. I certainly don't do this yet for peripheral vascular disease or diabetics, but as more data comes out, maybe I will in the future. So where are we going? I think higher level amputations would be a good place to start thinking about, including hemipelvectomy or hip disarticulation patients, potentially patients with flail limbs, or again, going back to that, patients with peripheral vascular disease or diabetes, Pediatric patients, I think, would be something that would be interesting to look at. There haven't been a lot of good studies looking at that, and likely for good reason, as a lot of these kids get around pretty well with the conventional prosthesis, and maybe it's what's more appropriate for them is to then wait until they're a young adult before you would potentially convert them over. And then as implants get better, again, restoring function, sensation, and proprioception with these prosthetics in combination with TMRIs, I think exciting directions that we're heading. So my references, I'll open the floor to any questions. Thank you for having me.
Are any of these being used by wounded warriors that have gone back to service?
Not who have gone back to service. Actually, if you look in the United States, the Department of Defense and at Walter Reed has performed the highest number of these in this country, and most of them have been that OPRA implant, which is the same one that I use. They have performed a number of these, but they're not typically for people who are going back to service. These are for war vets who have had an amputation, usually for a number of years, who then get their residual limb revised to this. There aren't many people that I'm aware of who are doing this for acute amputations. It's typically reserved for people who have had an amputation in the past and are having socket-related complications down the road later.
Thank you.
We do have a question from the Zoom. Ronald, do you want to unmute yourself and ask your question? Otherwise, I can. So he asked, can you comment on the degree of osteosensation that recipients of the osteo-integrated systems regain as a result of the direct connection of the prosthesis with the skeleton when loading?
Osteosensation?
Osteosensation, yes.
I can't comment on that aspect specifically. What I can tell you is from the handful of patients that I've done this with in the past is what they'll tell you is that ambulation feels more natural, that they feel a more direct connection between their prosthetic, the ground, their prosthetic, and then their residual limb. So they claim that it feels like a more natural gait to them. But I can't comment specifically on osteosensation in terms of their prosthetic being directly implanted.
Thank you. Oh, no, one more question.
Yes.
Just one quick one. So I know with the conventional prosthesis, like the femur, there's like a certain length of femur you need left.
Yes.
It sounds like with this you need less.
Correct.
But how much do you need?
So it depends. So again, most of the.
Can you make sure to repeat the question for that one?
Yeah, sure. So the question was for a conventional transfemoral amputation, you need a certain amount of residual limb left to don a conventional socket prosthesis. And how much do you need for one of these OI-based procedures? And the answer is, if you look at the type of implant that I would tend to use, you need at least 1.5, usually 2 centimeters of good cortical bone where you can tap into to get purchase. Some of the other implants may try to get away with a little bit less because you're press fitting and not necessarily relying on cortical bone that you're tapping. But if you look, I can try to go back here to one of the pictures of showing you one of these. 2 centimeters of bone that you need plus an additional little bit so that you have a cap. You can usually get one of these to fit even if you only have about yay much femur left.
Wow.
So obviously the more the better, but. Okay. Thank you again.